Hi, welcome. I'm Ole de Bakker. I'm working as an interventional cardiologist in Copenhagen, in Denmark, and I have the pleasure to welcome you to this PCR webinar. It's module 3 in a series of webinars on TAVI. And today's topic is how to plan and perform TAVI in more challenging anatomies with specific focus on THV deliverability, so cases with complex THV deliverability. So the learning objective, well, first of all, to learn how to anticipate anatomical challenges that may arise during TAVI with a focus as set on the deliverability, to understand how to plan for TAVI in patients with challenging access vessels. That will be the first case. And then the second case, also to learn how to develop effective strategies for planning and performing TAVI in anatomies involving a horizontal aorta, or should we call it vertical annulus. So as said, I'm Ole de Bakker, and I have the pleasure to be accompanied by, on my right-hand side, Matti Adam, he's a friend and colleague working in Köln in the University Hospital there in Germany. And we also have on my left-hand side, Won-Keun, working now very close to Denmark in Kiel, also in North Germany. So without further ado, I will maybe give a small introduction to this topic because, look, I mean, the TAVI implantation is one thing, but delivering the valve in a good, proper way and as coaxial as possible is another way. And how to assess, if we talk about the access, how to assess this feasibility for transfemoral TAVI, because this is normally the standard approach. Well, we can encounter issues with calcium, patients with peripheral artery disease, which is not uncommon because these patients with severe calcified aortic stenosis, they also not seldomly have calcified peripheral artery disease. This is around 6 to 8% of our patients who have this. On the other hand, we can also be confronted with patients who have severe tortuosity. And in some cases, there's even a combination of both, so then it becomes really complex. However, before we really go into this and cut into this topic, I think for me it's really essential that we discriminate between assessment of the puncture site and above the puncture site, the iliofemoral axis. Because if you have a virgin, non-calcified puncture site, as you see depicted on this picture here, for example, well, then I kind of tend to try to keep this case probably transfemoral if there's nothing really severely calcified or an extremely small intraluminal diameter higher up in the iliac vessels. You see on the right-hand side, this is, for example, a vessel which is, first of all, relatively straight. There's good amount of calcium, but the intraluminal diameters are still above systematically 3.54 millimeters. So a combination of these two, good puncture site and good calcified iliofemoral axis further down, further up, is not prohibitive for transfemoral access. So this is a case here, for example. Keep an eye on the left top image, for example. This is from Trimencio. Now I'm scrolling through the right leg, the right iliofemoral axis. You see in the iliac, the common iliac, and the external iliac, there's really a lot of calcium. I admit that, that's for sure true. And the intraluminal diameters go as small as 3.54 millimeters, so this is very calcified. But now I'm down on the puncture site, and you see, and the puncture site, it also involves a lot of calcium and really small luminal diameters. So that's, for me, probably not acceptable for transfemoral. If we look to the left leg, now I'm walking through the left leg. If you see on the left upper image, well, there's almost circumferential calcium, intraluminal diameters, 4 or 5 millimeters. This is modifiable, I would say, with intravascular lithotripsy or balloon. And you see there is, for sure, with a relatively high puncture, there is a calcium-free window to find for the puncture. So this is also what we did in this particular case, for example. We proceeded with transfemoral access, but you see we had a safety wire built in contralaterally, and we were treating this external iliac and common iliac with IVL. So this is first an IVL balloon, followed by a non-compliant balloon, and then afterwards we delivered our prosthesis. In this case, this is a case from a couple of years ago. That was a Portico case, which has a very small, nice introducer profile. And then at the end here, you see we had a nice closure at the end, so with no vascular complications. So this is doable, but you have to, of course, do a very good pre-planning. And the last 5-6 years in Copenhagen, where I'm working, we do a fully percutaneous TAVI program. So this means we do 92% of our cases with a standard transfemoral access. We push 3 to 5% of cases by calcium modification, whether it's IVL, intravascular lithotripsy, or maybe even some cases recently with orbital atherectomy. Then we have roughly 4% of cases left for transaxillary, whether you do this percutaneous or surgically assisted, that you have to see what expertise you have in your hospital. And then it's actually less than 1% of transcaval cases we have left. So this is just an example. Again, I want to repeat, you have to see with what context you're working, which expertises you have, skills you have in the team, and then take a decision on that.
So maybe one comment, Ole. I absolutely agree and would highlight the discrimination between puncture site and vasculature in order to assess feasibility. Yeah. Because I think this is much more important than the extent of the disease or even severity of calcifications. Maybe I would like to encourage the audience to engage with questions through the Slido app, and we will try to address all the questions. Yeah.
Indeed, we will try to address these questions during the webinar. If not, then we can also probably on the website also answer still later after the webinar. So, with no further ado, Matti, you have brought an exciting case from Cologne with us. You want to share with us?
Yes? Yeah, great. Thank you, Ole. I mean, thank you for this great introduction. I think very good context you gave us for the next case. And the next case is called high calcium, high stakes. So you might think maybe some calcium is involved. So it's definitely a theme that might pick up. So the clinical case presentation of our patient is it's a female 69-year-old. 180 centimeters of height, weight is 61 kilos, so BMI 18.8, so really not obese, really a small person. Clearly had symptoms, is a retired patient, active at home, but had exertional dyspnea, New York Heart Association functional class 3. So really symptomatic patient, and we definitely had to do something to improve that. Cardiovascular risk factors were arterial hypertension, nicotine abuse, hypercholesterolemia, so the classical one. But you see there's also some context in terms of concomitant diseases. There is an oncology history with right-sided tumor nephrectomy for urothelial carcinoma. There has been a gallbladder adenoma. There is obstructive lung disease with clear signs of pulmonary emphysema and CT. And there's also peripheral artery disease, stage 2, Rutherford, both legs involved. And you'll see more on this when we progress to CT screening. So overall, some of you might have seen the case. It was online on the website. So this is the clinical presentation, and I'm really curious about the ideas of you guys later. The coronary workup here was done by the referral site, which is shown here. And you see there is coronary artery disease. The left main is fine. There's no stenosis, only minor wall irregularities. But you see the LED has a severe stenosis of that more distal diagonal branch. The LCX is heavily calcified, has a proximal stenosis. Also further down, another, I think, significant stenosis. And the right coronary artery is heavily calcified. There's proximal stenosis, but also in the mid segments, I think there's really a long and very heavily calcified part, right? So clearly something to consider. And the referring site decided that the CAD should be treated. And what they did is they performed the IVOS-guided PTCA, so complex intervention rotational atherectomy, put 2 DES with excellent result in this LCX, but they failed in stenting the RCA was a non-crossable lesion. And I think if you remember the angio, this probably heavily calcified long stenosis is a challenging one. And
if I may comment on this, I mean, they did rotational atherectomy in a maybe not that easy vessel even. I mean, in a patient with severe aortic stenosis, this is not necessarily without any risk, I would even say.
I absolutely agree. And one of the discussions that we're having in our heart team is when do we do these PCIs, or do we even do them? Yeah. I mean, we know that the main lesion for this patient is the aortic valve stenosis, right? So I think we need to consider treating this.
Severe stenosis first. Yeah.
And then I think you barely see cases where you have ventricular functional problems during the TAVI. I think you see more patients where you run into trouble with patients with aortic stenosis when you do the coronaries, right? Yeah. But there's something that we need to be aware and watchful for data that's coming up and see how that goes, right? Yeah. And so the aortic valve workup here, you see clearly high flow, high gradient aortic valve stenosis. Pmax mean is 65/42. Aortic valve area is 0.8. Mild AR, normal ejection fraction preserved, and mild MR, mild TR, so clear-cut regular case, I'd say. And there is calcium. Calcium score here is 1800, and I do feel there's severe calcification patterns, especially on that one leaflet, and so really, let's say classical aortic valve stenosis involving calcium. If you look further measuring in CT, you'll see it's a 21.1 perimeter-derived diameter. The LVOT is tubular, same size, 21. Angulations look good. Coronary distances are good. You see the stent and the LCX there sitting nicely, and wide sinuses. So here I'd say nothing super suspicious to report.
But anyway, I mean, if I remember well, she was a relatively tall German patient, and this is a relatively small anatomy.
True.
So yeah, that's also something to take into account.
Yeah, it's only 21. You're right, and it's not. If you look at the eccentricity index, I think it's oval. So I mean. The minimal diameter, in comparison, especially in the LVOT to the maximum diameter, is really, it's a little bit elliptic. But now here's the fun part, femoral access in CT, and you introduce us very nicely to this topic. And if I just quickly go down the bullet points you just brought up, it's circular, it's heavily calcified. The puncture sites are involved, which you can appreciate on the right-hand side in the stretched vessel views. So for us, I think that's not a case that we would push transfemoral. And so we were considering alternative accesses.
Maybe if you go back, what's your take on this? How do you assess this? Is this still you would try go transfemoral, or it's a no-go? How do you assess this case? What do you see there?
This is a very good question. I think it's relative. Feasibility is relative. Yeah. I think if you really want to try it, then probably you get some kind of access. Yeah, but the question is, what is the risk? What is the risk-benefit ratio? And you might have some complications. So probably in this case, I would not go for transfemoral access.
Yeah. I mean, that's a great point, right? We all had these cases where we pushed it and pushed it and pushed it, and we got the valve in. And then, you deploy the valve, and then the real problem starts, because then you have to fix your femoral access, bleeding, and it can be critical there as well, right? So why not use something?
This would be, for me, also a bridge too far. I mean, if you look really, it's not a focal lesion, yes? This is complete diffusely diseased vessel involving a heavy calcium, intraluminal diameters which go below even 3 millimeters on both sides, and you see indeed the puncture site is involved with calcium, or even if it's like half a centimeter or a centimeter above the puncture site, you run into immediately calcium that's set to dissect to get you in trouble afterwards. So this would be, for me, if there would be for sure an alternative access, this would be a no-go for me.
Yeah. All right, I'm happy you said this. So, because we were looking at, as I told you, axillary access or subclavian, and you see that the right, I mean, that's also a no-go. I think it's heavily calcified. It's too narrow. It's close to the carotid artery. So right is really not feasible. But left, I think there's only spotty calcium. We have 6 millimeter vessel width. So I'm very happy with this. I think that's feasible. So. The procedural plan that we developed is a transaxillary left access, as you might have realized from the last slides. But also we decided to use a Navitor Vision 23 valve, and that's maybe another discussion that we can have. Is we're here right between the 23 and the 25. With the perimeter-derived diameter of 21.1 and LVOT of 20, average 20.9. We do have room in sinus height and width, I think, for both valves. Maybe access, would not be different because 23, 25 go through the same system. So that's not a point. But what are your thoughts, guys? I mean, would one?
Yeah, I think probably you could use both valves. It's a borderline situation. I think the main point should be that. And according to the manufacturer, it would clearly be 25, right? But I think we should not be too obsessed with a specific threshold. I prefer having some overlap. And what we should, or what I'm always looking at is the aortic root anatomy, the configuration. If you have large aortic root, so sinus, STJ, LVOT, then I trend to upsize. And if it's small, downsize. On the other hand, we should also be looking at the degree of calcification. If you have a lot of calcification, then maybe downsize. On the other hand, if there is low amounts of calcium, then you should probably upsize, especially in borderline situations.
Yeah, I mean, look, if you talk particularly about this valve, first, I think the valve choice is great. It's a small annulus, yes? So you're concerned about PPM, prosthesis-patient mismatch. You want a valve with good hemodynamic performance. So you automatically come with self-expanding devices mostly, and then with a good insertion profile, because you have a good transax, but still you don't want a really big, as small as possible insertion profile. So I think the Navitor choice is great here, the Navitor Vision choice. Then for me, a Navitor typically performs extremely well when it's on the upper side of the sizing range. So that means if you're really, really on the edge of the two sizes, typically I would keep it with the smaller size. And why is it? Because you have a better expansion of the valve. There's less stored tension in it, less constrainment at the inflow. So the valve typically remains much more stable also with the final release. And you have the same sealing, And also the thing is, in the old days, when we did core valve, for example, core valve or Revolut, if we were doubting, we easily upsized. Why did we do that? Because we were imperfect in our implant positions. We typically implanted a little bit too low very often. And if you took, for example, a core valve 29 and you implanted a bit too low, or it came to sit too low, it was not 29 anymore, but maybe only 28, 27.
Yeah.
That's not the case with this valve, because it's a tubular stent frame, so it remains very stable throughout the entire inflow part. And another thing is, if you look to the annulus and LVOT, the minimum diameter is around, we're talking about minimum diameters of 16, 17, 18 millimeter. Yes, 25 is massively oversized. Yeah. So even for conduction, etc., I think for sure, and the amount of calcium, it's moderate to severe. This is for me a clear 23.
Yeah. I like what you said, both. I agree, and that's exactly why we decided to use the Navitor 23, because no pinwheeling, good stent frame expansion. So that's actually exactly our thoughts. So let's see how that went, right?
But maybe we presented this case also to the audience, or we put it on the website, yes, and there was quite a good response on it. We asked, what would you do on this case before you really show what you did? You talked about your plan, but you see here, 54% of people, of responders, actually agreed with your approach. Yes, they say, I would do TAVI with an alternative axis in this particular case. So luckily you have the majority on your side.
I have the majority. That's already,
in a democracy, it's good. But on the other hand, you see also almost 1 out of 4 responders says, no, I want to still push this transfemorally. We discussed pros and cons. It's maybe not impossible, but you would have a hard time and a lot of work. Maybe also relatively expensive. You bring your patient maybe at some risks. Then the surgical, there's 10% of responders who says, no, this is for me still a surgical case. And that's maybe not surprising in a way, because on the other hand, I don't think so. It's surgical candidate. She's 69 only, but this is a patient with so many comorbidities. We saw,
and coronary artery disease. Yeah. So, we didn't put it up for nothing,
no,
that option.
But maybe some people would have reflected, well, this is more, you have to fix the coronaries too. So SAVR plus CABG, but 10% of responders said that. And then 11, 12% also went for fix the coronaries first. So maybe I don't know if they knew about this PCI in the referring center, or if they would even go on the right coronary.
It was known that the coronaries were partially fixed. We still have, technically we still have stenosis of the right end of the diagonal. Yeah. But so it's really, and we already had this discussion a little bit, when to fix, do we fix everything? Do the symptoms improve? That's what we do, right? Yeah. If the symptoms improve and there's no angina, usually, we'll take it step by step. And I think it's like the same discussion for coronaries in patients without aortic stenosis, right? You don't want to fix that peripheral diagonal. No. You want to fix that's what's relevant to the patient.
And there's more and more accumulating data questioning the relevance of coronary artery disease in this patient.
Well, yes, indeed, ProTAVI, and also it's not published data yet, but from Notion 3, if you look, it's revascularization before TAVI, yes or no. I mean, just in both arms, there was as good reduction and drastic reduction in angina symptoms. Just the fact of doing TAVI, but whether you did additional PCI before TAVI in one arm, yes or no, that didn't further impact or reduce angina symptoms. So that's maybe also important.
That's interesting. I'm going to look forward to that publication. Yes. I mean, it's really interesting.
Maybe before we proceed, is there time for one question?
Yes, I think so.
Okay. Are there specific algorithms for managing specific anatomic challenges, access and valve types?
I mean, there is a hostile score that has been published, for example, for transfemoral. It's not super easy to calculate, and what it reflects is what I think you mentioned in the beginning, and what we all do in our heads is like, is it tortuous? Is it circally calcified? Where are the, where is the calcification? How much is affected? So I'd say, there's nothing bad in actually doing it by an algorithm, but I think it's always said, things considered, I think that's in that score, right? And that's something that comes to mind.
And again, you have to look to the expertise in your center, what you're good at, where you're not. I mean, I know another German center, I heard a colleague saying, he said, like, look, we don't even bother about going, modifying the calcium. And for me, my percutaneous transax case just takes, I do it in local anesthesia, it takes just 10, 12 minutes longer than a regular transfemoral. And if I see it's a clean vessel, I just take that upfront. And that's a defendable strategy. If that works in your hospital, why not? Yes. So I think you really have to see what works best for you and not. I think you cannot pour it in one small, nice algorithm. You have to look a little bit what fits you best in your hospital.
I agree.
So let's maybe show what you did.
Yeah, so obviously I showed you guys that we opted for a transaxillary or subclavian approach, and we mentioned it already. It's like there's different ways of doing it. You can do it percutaneously. You can do it via open access. We, for example, do a lot of open access because it's in local anesthesia. For us, it's really a small cut. It's time-wise not a big effort. So, but it really depends. You just mentioned it. What's the expertise at your center? And then also, like, what's your position on the table? There's different ways of doing it. We, for example, you'll see opt for option A, where I stand exactly where I stand usually if I perform a TAVR, and have my surgeon helping me out on, holding the system and helping me implanting the valve on the left shoulder. And so that's a setup that for us works nicely. But I'm not saying that's the right setup. We had this discussion. I think it's really good to understand what works best in your setup. So after we established access, you see there's a sheath in place, balloon comes in, pre-dilatation, and you see hourglass phenomenon. I think there was really a lot of calcium, but the balloon expanded very, very nicely. So I think that's a good pre-dil. We brought in the system, and then, when we talk about patients with coronary artery disease, especially if we're saying, there will be some stenosis that might come up in younger patients, maybe later for treatment, I think commissural and thereby coronary alignment are important. So we're looking in cusp overlap on the left-hand side for a 2-1 configuration of the vision markers, which we have. We confirm height. Also, I think height-wise we were good on the non-coronary side. We confirm height on the left. You see 1-1-1 configuration. Again, we're happy with commissural alignment and height on the left. So we decided to implant this valve, hit the safety button, hit the safety knob, and just slowly retracting that capsule. Take your time, hemodynamically stable. And the more time you invest here, I think the more stable is your valve deployment, as you see there. So stable valve deployment. And then that's our first angio. And I do feel there's some underexpansion, especially in the inflow. You can also see there's some PVL. So we were before thinking...
Even, Matti, I think if you really wanted to screen for underexpansion, I think you could have typically gone more REO.
Yeah.
And
cusp overlap almost.
And even a little more than cusp overlap. If you go, we have done some preliminary study there. If you go cusp overlap and even add 10 or 15 degrees of REO, that's typically the minimal expansion view on your prosthesis. So because it's a tricuspid view, you have your 1-1-1. But true, you had the suspicion already.
Yeah, so. I mean the PVL was for me, okay, we're not gonna leave it. But I mean, you made a great point. If you really want to see underexpansion, it's REO caudal, right? I mean, you can even in 3-Mensual before try to find out where your minimal diameter is and stuff. Yeah. So really good input, Ole. So 20 millimeter balloon postal, rapid pacing, everything is stable. I like the position of the balloon. It really folds up nicely. And then that's the result. Height-wise, super happy, I think, result-wise.
And if I may, this is the 23 millimeter valve you chose. If you look to the aortic roots there, I mean, it fills it nice. It has nice contact even with the aorta, so aortic wall. So a 25 wouldn't have helped you anything.
Yeah, 25 would have probably been too large and maybe more challenging during the deployment.
Yeah. I agree. So super happy with the result. I mean, a great effort. And just to follow up and give you all the details, pressure was 12/7. We had no PVL, almost no PVL, maybe a little minimal there if you want to be very, very spectacle. But no AR, significant improvement in symptoms and no angina.
No angina.
No angina.
So, Won, would you bring this patient back for PCI, by the way? No angina anymore. Would you do something about that right coronary? No.
It really depends. It really depends. I wouldn't change my practice. It would be independent from having aortic stenosis or not. So if there's no angina, you have to really think of what you do to the patient, whether it's prognostically relevant or not. And in most cases, chronic coronary syndrome treatment is not prognostically relevant. So especially if the patient is old, 80 plus years.
This was not the case here?
It was not the case here, but just basically, it's a basic discussion whether this is really necessary to have full revascularization. So I really
You had a couple of questions, you said.
I have maybe one or two more questions. And after finishing up the case successfully with, and you chose, and I think it's very justified, an alternative approach. There's one more or less provocative question. Femoral approach is easy to manage in terms of complications, and this can be easily detected, and a graft stent from contralateral side can be installed by a junior interventionalist. Oh, wow. So what is your opinion? Wouldn't it have been much easier?
I like
Matti,
that question. I like that question. But I have to contradict that. I think that managing femoral complications can be very difficult.
It's a matter of preparation there again. Look, I mean, I do a lot of hardcore femoral stuff, I would say, but I only do it when I'm prepared. You have to almost anticipate something may happen. I have a plan B, even plan C. I use very often safety wire, especially if the puncture site could become problematic. You have to have a plan. You cannot just say, I proceed, I jump myself, throw myself into this case and I do it. No, you need a plan. So it's doable, but I also support the vision that, look, this is too much work, too much risk, and if you have money even. I mean, if you have a really good, smooth alternative access, that's equally defendable.
And I'm on the other contrast of that comment because we do open access transsubclavian because it's so controlled. I don't even have to bother about bleeding. I see it it's a suture and it's done. So I think that's very easily manageable. But in femoral, it's like, of course there's to the point to deploy a stent graft can be very easy. But there's bifurcations, there's dissections. There are calcification patterns, and so in detail it might be sometimes more difficult. And if transaxillary is a good access, I agree with you. I mean, just go for it. I mean, why drive a beaten up car if you can have a new one? So, I mean, for the same money, for the sake of the example.
You want to ask one more question, Won, or I know you want. If you have
maybe one more question. Why not skip coronary angiography invasively or maybe non-invasive at all?
Question. Yeah, I mean, in this case, so I'll tell you what our algorithm is, and then maybe you guys can share.
This was in the referring site, I guess.
Yeah, it was the referring site that made the decision for us. But even if the patient came to us first, we would have seen CT, a lot of calcifications in the coronary vessels, and then I'm still not brave enough to not do coronary angiogram because I really want to rule out supercritical stenoses. And I do trust, I'm a cardiologist, interventional cardiologist, so I trust angio. But I mean, it's still, it's still moving parts.
I think you have to look case-based because this is a young patient.
True.
You would see calcifications, patient has angina. I would probably on my center there would have also been done an invasive coronary angio. It's very different if you have an octogenarian with very little comorbidities, no coronary artery disease known before. no angina, I think we're almost there with the answer that it's not mandatory. Yeah? So there, it depends very much from the context, from the scenario, from the patient.
Yeah, and also I think it's something that might be a regional comment as well. So it might be different in Spain, or it might be different in France than it is in Germany. And for us, like once we see these patients, we kind of have the feeling that we, at least have to rule out everything, make a plan, be very specific about what's next, and not, leave coronary artery disease maybe to the referring hospital or something. So
enough talk about the coronaries. I think maybe a final thing, you wanted to share something from the Gary registry. I wanted to make one comment on that very quickly before we go to Won's case. Yes?
Yeah, so just quickly, this is data from the German aortic valve registry, and it shows non-TF-TAVI cases. It's a busy table, but what I want to show you is that, we compared TA aortic, or so transapical transaortic transaxillary, and also cut down transaxillary, and there are differences, let's put it that way, in terms of bleeding complications, in terms of stroke rate, not statistically significant because the numbers are small, but there is a discussion that we could have.
Yes.
And
I want to comment on that. Look, I mean, I know in literature that there has been some tendencies the last couple of years that in the transaxillary cases, there was maybe a signal of slightly higher stroke rate. To that sense, I mean, I've changed my approach doing these cases, percutaneous transaxillary. What I do the last 3 years is systematically use an introducer sheet. So I use, for example, for this case, I would have introduced an 18 French, for example, dry seal sheet, introduce it all the way up to the aorta, and then all the maneuvers there, whether I go in with a balloon in, balloon out, valve in, valve out, maybe balloon in, balloon out for the pulsatile. I mean, you go protected through the sheet, just as they do for transcarotid, yes? Yeah. In the early days, we were not doing this. We were putting a 14 French sheet in, sometimes even just the horizontal part. We went with a balloon in, balloon out. We passed 6 times sometimes by these cerebral vessels. And then, of course, there has been a signal of higher stroke. I can share, honestly, that in the last 50 cases done with the approach of introducing the sheet to the aorta, transax cases, we had 0 strokes in these patients. So I think this is maybe a point to consider. If you can do it by an introducer sheet, it's maybe better than all the change to do there.
And that's exactly why the slide is there. There is some, we can still improve this technique.
Yes.
I think that's
exactly.
Yeah.
Okay, but thank you very much. Great case, great discussion. We move on. Won, you also brought an exciting case and an educational case, I would say.
Yes, thank you very much. And I think this case aligns well with our main topic of difficult deliverability. And in this case, you will see that the vasculature, the femoroiliac vasculature is okay, but the main problem is in the more downstream in the vasculature. And you will see that, or we know that even difficulties in the aorta can translate into, can compromise delivery. So this case is an 84-year-old female patient. She was symptomatic with severe aortic stenosis. You can see the comorbidities, nothing very remarkable. And the first glance, you would say it looks like a straightforward case, but I would never assess a case, evaluate a case difficulty alone just on demographics. And let's continue. Here you can see echo data, more or less preserved ejection fraction, also right heart function seems to be okay. You can see there's almost high gradient with approximately 40 millimeters of mercury for the mean gradient. So, we had this discussion, and also in this case, coronary angio was performed. It's open to discussion. I mean, the new guidelines, they say it depends on the pretest probability, but in this case, it's a little bit older case, so, but you can see no remarkable target lesion in the coronary angio. But I think for TAVI workup, CT stays the key instrument, the key modality to assess feasibility, risk certification, and to employ a good strategy. You can see the annulus diameter highlighted on the left-hand side. Perimeter derived is 26.4, so on the larger side for a female patient. Further down, you can appreciate the aortic root dimensions, which we discussed. SOV is 37. STJ is also rather on the larger side, and LVOT is indicating rather some tapering. Aortic valve calcification is mild to moderate with a more or less symmetric distribution. It's difficult to see, but you can, you have to believe me that coronary distance to the left and right coronary artery are okay.
And if I may interrupt you there, Won, I mean, so this valve looks bicuspid a little bit to me in terms of calcification. What's your workup to, you know, was that a bicuspid case or was it not?
It was not a bicuspid case, but it's a very good point. The distribution could suggest a bicuspid morphology also due to the aortic configuration. I think in those cases it's very important to scroll through the short axis of the CT, both in diastolic and systolic reconstruction. And this will really demonstrate whether it's a bicuspid or not. And as I mentioned, if you look at the iliofemoral vasculature on the right-hand side, it's unremarkable. So it's a straightforward femoral axis. But you can see that the main issue in this anatomy is the horizontal aorta.
Yeah.
So, and this derives a very, or demands a very careful planning. And on the first glance, it looks like it's not very demanding, but horizontal aorta can be challenging in several aspects, as shown here. You can have difficulties in crossing the valve. You have to really think carefully of which wire to choose and how to position it optimally. Predilatation is of relevance here. We will discuss later why. And obviously, there can be problems in advancing the delivery system, not only across the aortic arch, but especially if you have such a horizontal configuration across the aortic valve. Difficulties can advance to coaxial alignment of the prosthesis. We will show you how to address this. And the procedure is not finished after deployment of the valve, but especially in these anatomies, the retrieval of the delivery system can be challenging. So this is our strategy that we planned in the heart team. I think ultrasound-guided puncture is standard nowadays. We had a secondary access in the left groin because radial access was not feasible. We can discuss on that. Single prostyle is quite common today. We took a 14 French placeholder sheath. And in this case, due to a rather large anatomy, we opted for a Safari S-wire. And predilatation was performed with a 24 millimeter semi-compliant balloon. And I think in this case, sizing is relatively clear in the range of a 29 millimeter Navitor vision valve.
So Matti, would you agree with this? Anything else you would do different or could have other considerations?
Yeah, I mean, basically, I'm very happy with Won's procedural plan. Probably the same. We would have done the same. Maybe adding, one more prostyle, debatable. And also, I would have chosen a Safari. I do think that you can have an argument for a stiffer wire, maybe a Lunderquist, to get a little bit more outer curvature. I personally like the Safari. I have a lot of experience there, so I like the interplay with the wire is something that's somehow embedded in my brain. So I would stick with the Safari, but I do understand the argument of the Lunderquist. And then if you have, sometimes these cases also have tortuous access, not this case, but then, going not inline sheath, but maybe using not a placeholder sheath, but like a proper 18 French sheath is something you can consider. But I'm very happy that would have been exactly the same for us. Yeah.
What do you think about predilatation? 24 millimeter? Audience might think maybe it's too large, too aggressive.
No,
yeah,
it's not.
Especially in the horizontal cases, you want to move that calcium, right?
You want an effective look. I mean, that predilatation, balloon size, etc. If you want an effective predilatation, it's perimeter-derived mean diameter minus 1 millimeter. That's for me an effective predilatation. Everything that goes below that, then you just do a predilatation to facilitate the crossing of the valve, but it doesn't necessarily give enough fracturing, modification of the calcified leaflet. So I think I agree with all what you said. One thing which is maybe interesting, which we didn't discuss, I mean, you had now no radial access feasible, but I think if there is one particular anatomy, if you go in, where I want really a femoral pigtail, it's this, a horizontal aorta or a challenging aortic root, because having that pigtail coming from the femoral artery and not coming from the radial, typically the pigtail will take the outer curvature, yes? And without giving any contrast, I see immediately during the entire deployment, I see continuously where is the outer curvature of this aorta. If I come from radial, typically my pigtail goes straight vertically down, sits in that sinus, and I lose that information. So doing self-expanding technology in a horizontal aorta, I push typically my fellow to say, let's take bifemoral. That's something.
That's a very good point. I mean, there's value in this. Yeah, absolutely.
Yeah, very good point. I wrote that as excuse, but but in some cases might be you might be
you get
better
information
off,
out of that, and that's important.
And then can even push a stiffer wire through if you need a body wire and stuff like that.
So, but you touch on the horizontal aorta, and I want to crack that discussion a little bit open because we use the terminology horizontal aorta like here and there, and do we really discuss and mean the same? I mean, look. These are two different cases, which we treated in Copenhagen over the last couple of weeks and months. And you see first of all, what is the difference, how to measure the angle, yes? So you do this strictly in the tricuspid view. Don't do it in a cusp overlap view because you will typically see less angle, yes? So you measure this angle in the tricuspid view. You measure your annulus angle to a horizontal plane. So here you see it's around 65 in both anatomies. But is the complexity of these two cases the same? Well, for me, not necessarily. Look, if you look to the left case, this is, that's why I'm not sure the horizontal aorta is the right terminology. It's maybe we should talk more about a vertical annulus plane, because it's a vertical annulus plane, and then you see an aorta which has such a bit of hockey stick aorta. There's a short runway and it goes immediately vertical, whereas on the right-hand side, you see a nice long runway. So to me, having this anatomy, this may be challenging, especially if you come with self-expanding technology, which is maybe a little bit stiffer, maybe Evolute or VitaFlow, that may not be my first choice necessarily, because you would come from the inner curvature and you would have a hard time to get a symmetrical implantation. That probably almost impossible. Whereas on the second case here, with also the same vertical annulus plane, but a long, nice runway to it, that's no problem for any prosthesis, I would say. Matti, you do JenaValve too, and for JenaValve, this is, for example, one of the criteria. They measure that distance from the annulus plane to the aorta, and you need kind of 55 millimeter. Otherwise, it may be more complex. So.
Yeah, it's just, it's exactly the argument you're making right now. Like if you have this discrepancy in angulations, like if you have this hockey stick, right, you really come down and then you have to make a sharp turn in a small room. I think it's difficult for most, if not to say all, TAVI.
Navitor is then still doable. I would say it's doable typically, but it's a harder time. But it's impossible with almost or to get a real proper good result with stiffer self-expanding. But to go back to your case, maybe want to tell us what you did.
Okay, no questions from the audience?
Well, there are some questions regarding axillary access. I mean, in the end, if we have time, we can still do that. But otherwise, just write me an email, guys. We can follow up on this.
So we touch upon the procedural challenges and how to approach this. And let's start with aortic valve crossing. And you can see the video of how we did it in this case. You can see the horizontality or the verticality of the annulus plane. In this case, we used a regular AL1 and a J-tip wire. And on the right-hand side, you can see a table. There are many different approaches. And especially for my personal experience is horizontal aorta EBU 3.5. Maybe you have different approaches.
For me, that would be straight wire JR4, but I think there's no wrong or right. I mean, it's just what's used through that valve, right?
Yeah. And so you can see, I didn't shorten the video. It was difficult, but eventually you'll be able to cross the valve. And for me, the advantage of using a J-tip wire, especially in those horizontal aortas or also in bicuspid aortas, they frequently have very asymmetric openings. It's that is less traumatic, and you can see how long it took. and
I
several...
mean, look, what can you do if you have difficult crossing? There's three things you can fiddle on, yes? It's either take another catheter, another wire, like this is J-tip, you can go for a straight tip, what I do, or a Terumo wire, what many people do. And thirdly, you can change your view, yes? Yeah. So these are the three aspects, and typically it's a matter of patience, typically you cross, yes? But
I agree, and you know, I'm always in favor of, like, you know, trying, and if it's not working, just quickly change something. Exactly. Otherwise, you just spend time and look for the jet. I think that's something that you also might want to do. Is like, you know, try to find the jet. So if your catheter moves in the jet, you're almost there. Right?
I agree on that.
So, but you can see that finally we were successful in crossing the valve, because this is now the balloon valvuloplasty, and we discussed previously about the importance of effective pre-dilatation. As you can see here, and you can see the dock boning here.
Well, what we can say here, maybe you want to comment on this, Matti. I mean, I think this is an absolute must to predilate, because your wire sits in a not optimal position. It sits curl upside down. You don't sit with your wire in the right commissure between the right and the non on the outer curvature, which would push the wire in the commissure between the right and the non. So you're not. So very often, if this is, for example, would be a difficult bicuspid case, then also just the fact of predilating sometimes let your wire fall into the right commissure and on the other curvature.
I totally agree. Yeah. I mean, it looks like a bicuspid RN in the first wire position, I think. So you made that room to, you know, let the wire now, you know. But I mean, wire position is super important. I agree. I mean, I think.
Yeah, absolutely.
Yeah. So, but in this case, what I would like to emphasize is balloon valvuloplasty is not only important for better valve expansion, because nowadays stent frame expansion has become more and more important, but it might help for facilitating valve crossing in this specific challenging anatomy, and maybe also help to have a more stable positioning during the deployment.
I mean, look, many people, if they do balloon expandable valves, they don't have the habit to predilate, but if there's any anatomy, it's either bicuspid or severely calcified or horizontal aorta, where I do predilatation for sure too, in any.
It helps you with everything. It helps you with everything, with valve positioning. Like your slide is perfect. Yeah.
And I know that sometimes you even do twice, right?
Yes, why not?
Very effective. Okay. Yeah, and you already mentioned the importance of wire positioning, and this is summarized here again. And I'm taking a lot of time to achieve a very good wire positioning. You should absolutely try to avoid, for the bespoken reasons, to avoid upside-down wire. You should avoid mitral apparatus entanglement, and I think especially if you have such a difficult anatomy, a good wire position will help you to achieve a better coaxial valve alignment. So just take time. I'm not satisfied with a suboptimal wire position. No. You might also experience hemodynamic compromise if you are entangled in the mitral valve.
But look here, here the wire flips suddenly, and see how and look what a kind of a super nice long, I call it a runway you have to the annulus plane. It's great. Whereas first it was upside down, it would be difficult, hard time to get the cross, good coaxiality. You would run for one, it's an avalanche of problems then, yes? If you would accept that and come with your valve, you would go with one problem and the other. No, it's better to take a minute time to get your wire position like this and then proceed.
Okay, after fixing the wire position, the next step, of course, is crossing the aortic arch and valve. And I have summarized different approaches, technical approaches, instruments, devices that could be used. And you can see that it was difficult to cross the aortic valve. It's an interplay of angulation, etc. And you could try using a stiffer wire, which you already mentioned, body wire techniques. You can insert a second balloon. Some operators would use a snare or even a long sheath, which probably only would help for the aortic arch, or even such techniques such as shown here, to employ clockwise rotation of the handle and maintain wire tension. No matter how you do it, it's important to get crossed across the aortic arch. And then I think a major challenge that we have in these anatomies is the initial positioning and flaring. You can see different stages during the implantation. I think it's of high importance to achieve a controlled release. We use also fast controlled pacing. And you need to really make sure that you have good flaring until there's contact with the left coronary cusp. Once there's contact, you can be relatively fast with the deployment until you reach the safety knob.
Before proceeding here, maybe, look, if you look to the, do you remember, I think it's a case from a couple of, a while ago, but do you remember, was this a tricuspid view or cusp overlap or LAO view? Because to me, this looks more like an LAO view because you see the ascending and descending aorta are like an arch is opened. Yes, this is to me not a cusp overlap view. And I think that's the right thing to do, what you did there, because look, the thing is, working in a cusp overlap, the classical right-left cusp overlap view, typically you have the ascending and descending aorta very often overlapping. So the information you miss there is where are you with your prosthesis? Are you outer curvature, center or inner curvature? And for a Navitor platform in a horizontal aorta, it's extreme. I mean, it's essential information during your deployment to know, am I sitting like here, completely glued to the outer curvature or not? So I think you did the right thing there, but that's maybe not according, I mean, if you want to stick absolutely to cusp overlap, I think that would have maybe been even a mistake. I think you should go out of that, maybe go tricuspid or even a little bit LAO and correct for your parallax and then do it, and then you can see this, yes? What do you think? Do you agree on that?
I totally agree, especially in a system that's as flexible. You mentioned it, like the Navitor system that you used for this case. I do think that, you know, your left view and your left coronary cusp and your coaxiality are super important. Yeah. And that's information you only get if you go more LAO. And I mean, it's exactly what this video shows, right? Your super outer. Yeah.
So even I think if you do Navitor implants with cusp overlap, I think before I do that, I always have a look in my LAO, by the way. You have it anyway because you do the crossing in the arch in an LAO. I check where is my prosthesis, is it very outer, center, inner. Typically it's more center or outer, but that's extremely important information if you would go to cusp overlap or in some, like if I use a Navitor 35, I don't even go to my cusp overlap, I go tricuspid, I'm correct for my parallax typically because it's so essential, like in this case also so essential to know where that prosthesis is, so I get out of that cusp overlap. Yes.
Yeah, you're absolutely right, and it's probably new to the audience, but Abbott is following up for a new approach to implants.
And it makes sense. It's in line with what we're discussing here, what we as implanters feel is essential information, so you have to adopt that in your implantation technique. Yes.
So but, there might be some paradigm shifts. Yeah, absolutely right. Yeah. Yeah, and here in this angio, you can see the first position, and you can see we have reached the 80%, the safety knob. And usually at this stage, the patient is stable. You have sufficient time to evaluate the position, which is important. Look at the non-coronary cusp and the left coronary cusp. And I think this was probably also in the, some LAO angulation. And with this position, we were not satisfied, and we tried to resheath.
Well, would you, so one was not happy with his team.
I wouldn't have been happy as well. I mean,
and why not?
You're not coaxial. You're high on the left, you're deep on the non, you're super outer. The valve might actually move, you know, centralize a little bit more when you release it. And then it's probably coming down on the left, and you're deep on both ends. And so, I mean, I agree with you. We would have not accepted. And you also have parallaxes, right? So it's a lot going on here.
But look, it's very important what you say there. You say it in a bit a nonchalant way to say, because it's so easy for you, logical for you. But if you look to this, look, the thing is, there's one certitude in life. When you release stall frame valves, they will always follow the aorta. Yes. So here you see your valve is sitting. The outflow part is sitting pushed to the outer curvature. So when you release, what can you anticipate? That the valve will expand, especially to the left main side, LCC side, and it will go down on the LCC. So you're sitting already at 10, 11 millimeter on the NCC, so you can be sure almost that on the left side it will follow the same and dive to 10, 11, and that's not what you want. So indeed, it's completely correct, but you can anticipate it, and many forget that, in fact, these tall frame valves, they will always follow the aorta with the final release. That's why they sometimes also cant a little bit or so. Yes.
Exactly, and this is, so we were not happy, and if you're not happy with a result, you have to follow a new concept. And what we did in this case was, and this can be considered as a general recommendation in horizontal anatomies, we started higher at the non-coronary cusp and did the push-push technique to obtain coaxial alignment, so push the wire.
Maybe you can show it.
Yes. Unfortunately, it's not shown here. But
it's not shown. Okay.
It's not shown here. But
so but you clearly have another position. You're not that much in the outer curvature anymore. Yes. Also?
Yes. And on the left-hand side, you can see the position after resheathing, and in the center you see the full release. And this image also highlights what you mentioned, that you should always anticipate potential tilting to one or the other side, and that this might change the implantation depth and trajectory of the valve. And this is the final outcome. You can see how horizontal the valve is lying, and that this is obviously a very difficult anatomy, but nonetheless, we were quite happy with the outcome. It was challenging in many ways. I think we've shown you, starting with the crossing of the valve, the wire positioning, etc. And there were challenges in many steps, but I think if you have a good approach, a good strategy, you can achieve satisfactory outcomes.
Yes. Maybe we have 2-3 minutes for questions, if there's some questions, Matti.
So there's, first of all, I can extend thanks from the audience to you guys. Some people are very happy with the webinar, so thank you also for telling us. And also, there are some questions related to, a little bit more the topic we had before, the transaxillary access. And maybe just, there's one statement that I'd like to mention. That are self-expandable valves more feasible than balloon expandables in alternative accesses? What's your opinion, guys?
Well, look, I mean, if you go alternative access or transax, then there's always two things to consider. First, the insertion profile, yes. And of course, insertion profiles of self-expanding technology is still, to me, in a way, better than, even though you can bring it to the expandable sheets, but the moment you push this balloon expandable valve through, it still gets to a bigger diameter, so that may be a limitation. Also, using sapien is not always easy for most to load the prosthesis on the balloon. That's not an easy maneuver because you have very short length.
Especially if you come from right.
Yeah, so in that way, honestly, I mean, if it can be done with Navadar, I almost favor it because it's extremely flexible system, and that's exactly what you want if you do transax, because all the lengths are extremely amputated. You need a flexible system, to be honest.
Yeah. Same.
Yeah, I think procedural considerations are important, but I think you should also integrate aortic root, aortic root factors, anatomy, and you still have to think of risk of PVL, prosthesis mismatch, coronary access, etc.
Yes,
and this should be integrated in the final decision. But I think, especially if you have problems with the access, I think this is a major criterion.
And then maybe short, maybe I can bring it down to a short question. Running Lima LAD, would that be something you guys consider dangerous, not doable, doable? What are your thoughts? I start with one.
I'm rather against it. If you have other options and you have a running Lima LAD going across with a sheath, you could have ischemia. And especially if it's your last remaining vessel, I'd be rather reluctant, but I'm happy to hear different thoughts.
I do it, unfortunately, but I don't want to say people have to do it. But look, I mean, sometimes the only way. And look, sometimes also pacemaker there, yes. Yeah. You can also do nicely echo-guided puncture there. I mean, having a pacemaker there, I always find a way next to it or below it or beside it. Having a functional Lima, I've done several cases without any issue. What you do then, you adapt your style a bit. Before, for example, you do make a puncture, pro styles, 8-French sheet in. I don't bring the big sheet in, introducer sheet right away, and no, then I cross the valve already, stiff wire. So you keep that potential ischemia, but I never ran into ischemia, by the way. You keep it to an absolute minimum. So it's doable, but okay, I don't say it's the way forward, but if it's the only way, left, I would definitely not say it's not possible because I've done it.
Yeah, but it adds more complexity, let's be honest.
It adds complexity.
It's like, it depends on the other options you have,
Absolutely.
right? And I'd say in planning, if you have +2 millimeters, maybe +1, you're safe. But I've ran into problems and those were dramatic. So it's a very good thing to consider.
But look, I want to thank everybody, also the faculty. I want to thank the faculty. I want to thank PCR for organizing this. I want to thank also Abbott for supporting this these webinar series, actually. And I also want to thank you for participating and logging in on this call. I think if, as a summary maybe, I think we tackled, if we go back to the learning objectives, I think we really tried to give you a flavor of anticipation, planning, anticipation of potential challenges, complexities. That is the trick of doing good TAVI, you know. I mean, for me, this is it. What you do before you step into the cath lab, that's as critical, as important than your skills in the lab. It's anticipation, it's planning, foreseeing complexities. That's what we tried to teach here and discuss. Then we went into, zoomed in on challenging access vessels, which was great by Matti's case. And then also horizontal aorta, or should we from now on say vertical annulus case by Won. So again, I want to thank everybody. Also, I want to say that you should receive a survey after this. If you completed this, look through this whole webinar, you should receive a survey. And also you should be granted CME credits. So again, thanks for logging in and on this webinar. And we see you maybe next week at EuroPCR in Paris or on one of the future PCR webinars. Thank you all.
Thank you.